Hello, should we start? Hello.
Just a minute, sir. Yes, it's 3:30, sir. With all your due permission, can we begin with the session? Sir, am I audible? Hello?
Yes, I am very much. Can we start now?
Yes, sir. With all your due permission, we are beginning with the session for today, sir.
Are you introducing or should I start straight away?
No, sir. I'll introduce you on the topic, then we'll be handing it over to you.
So please.
Yeah. Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. He is none other than Dr. Banshi Sabu, sir. With great pleasure, I would like to welcome him at our platform. He is MD and consultant at VR Care in Ambawari, Ahmedabad. With the help of sir, we'll be taking a close look on today's topic, which is hypoglycemia in adults with diabetes mellitus. Before moving on to today's session, let us have a brief look on what the topic says. Hypoglycemia or low blood sugar is a common complication in adults with diabetes mellitus, especially those taking medications that lower blood sugar levels. Hypoglycemia occurs when blood sugar level drop below the normal range, typically less than 70 mg per dl. Managing hypoglycemia is an important aspect of diabetes care, and it requires close monitoring, careful management of diabetes medications, and proactive measures to prevent and treat low blood sugar levels. We'll be knowing more about the topic with the help of sir's wonderful inputs regarding the topic. So now, without any further delay, I would like to welcome sir at our forum and would like to hand over the session to him for his talk to begin. So over to you.
Thank you, IGCP, for this wonderful opportunity. Thanks, Talks. Nishita, I'm really thanking you for giving very important and very interesting and clinical topic in hypoglycemia, which is really a challenge in diabetes management. And the hypoglycemia in adults with diabetes is really a very, very challenging situation for many of the clinicians too. To start with, the American Diabetes Association had given the definition of hypoglycemia that any abnormally low plasma glucose concentration that exposes the subject to potential harm with a proposed threshold plasma glucose value of less than 70 milligram. This is ADA in their guideline in 2020, and even before also and after also in many of their annual guidelines which they publish, they have written very clearly the definition of hypoglycemia. Hypoglycemia is responsible for significant impairment of intellectual and physical activity. If it is prolonged or severe, can result in seizures, coma, permanent neurological damage, as well as death. Even in cases of mild hypoglycemia, which are treated or resolved by the patient, cognitive dysfunction lasts for several minutes after recovery to the normal glycemia. So this is what hypoglycemia can lead to. Now, this is very interesting that hypoglycemia is really a limiting factor for treatment of diabetes. Otherwise, if you start any patient with any medication, you will be able to achieve the tight glycemic control. But we can't get because of the hypoglycemia. Hypoglycemia is the biggest limiting factor. It is fear of hypoglycemia, which is responsible for hindrance to therapy. Even in an ACCORD trial, which I will be talking later on also, that it is associated with severe other untoward events, and the cost of burden because of hypoglycemia, patient get hospitalized, admitted, they have to do more frequent self-monitoring of blood glucose, and then there is indirect cost also, that work disability, absence from work, reduced work capacity, as well as the accident which can occur because of hypoglycemia too. Now, in a survey of diabetic patients between the age of 16 to 94, the adult age group is 18 plus, in Germany, UK, and Spain, showed that severe hypoglycemic event represent a substantial burden of national healthcare system. So you can understand how hypoglycemia is important. Even for a national healthcare system, it is a substantial burden too from the western part of the world, which is Germany, UK, and Spain, with their data. If I classify the hypoglycemia below 70, we call it mild. Below 54 or below 55 or below 50, you can say it's a moderate, and definitely below that, we call it a severe hypoglycemia when it goes less than 40 milligram of this. So this is a one paper which we had classified, the Sanjay Kalra, I was the part of it. And this paper is talking about what is mild hypoglycemia, what is moderate hypoglycemia, and what is severe hypoglycemia. Mild hypoglycemia is associated with presence of autonomic symptoms and individuals are able to self-treat. So most of the time, they have some autonomic symptoms and they may get themselves also self-treated too. In a moderate, it is autonomic as well as neuroglycopenic. Both symptoms are there, but still individuals may or may not, but mostly they are able to self-treat. The severe hypoglycemia require assistance from another person, and sometimes they may become unconscious where hospitalization is also required. The signs and symptoms of hypoglycemia is divided into two. One is autonomic symptoms, other are neuroglycopenic. Autonomic nervous system symptoms are manifested as a cause of activation of the sympathetic nervous system, trembling, palpitation, sweating, anxiety, hunger, nausea, tingling. Neuroglycopenic symptoms are enlisted in response to decreased level of glucose to the brain, difficulty in concentrating, confusion, weakness, drowsiness, vision changes, difficulty speaking, headache, dizziness, and tiredness also. Hypoglycemia caused by treatment like sulfonylurea, glinides, and insulin. These are the three major agents of treatment of diabetes which can lead to hypoglycemia, and other agents which are not actually hypoglycemic agents, but they reduce the glucose level too if they are used along with the molecules like insulin, sulfonylurea, and glinides. It causes recurrent morbidity in most people with type 1 diabetes and many of type 2 diabetes who are on sulfonylurea and insulin, and sometimes it can be fatal. It generally preludes maintenance of euglycemia over lifetime of diabetes, and it impairs physiological and behavioral defenses against subsequent hypoglycemia. The shifting of threshold for hypoglycemia detection is, it's a chronic hyperglycemia versus recurrent hypoglycemia. A person who has having a hyperglycemia, which is a sugar is very high, not keeping very good under control, it also leads to complication. At the same time, it is the hypoglycemia which also causes acute problem. So most of the time, what we want is a specific range of the sugar should remain. And if it is either on higher side or lower side, both is causing the problem. And this threshold, sometimes with the shifting with the threshold, the patients may get sometimes relative hypoglycemia symptom. Also, you are keeping all the time your sugar more than 200 and suddenly keeping it 130 or 120. Sometimes they get relative hypoglycemia symptom too. AD and Endocrine Society have also divided this hypoglycemia in a different classification, that severe hypoglycemia, documented symptomatic, when it goes less than 70 and there's a sugar has been done. Asymptomatic means sugar had gone, but patient does not have symptoms. It might be detected on continuous glucose monitoring. Probable symptomatic hypoglycemia, patient had have a symptom of hypoglycemia, but it was not checked, not documented. So there is a probability comes. Relative hypoglycemia, which I already told you that patient had gone in sugar level from high to low and patient is having symptoms, but actually while checking the sugar had not gone relative less than 70. So there is a joint position statement by IDA as well as ESD on this, that how we should classify the hypoglycemia. There are multiple factors which are contributing to increasing the risk of hypoglycemia, whether it's a young children or a type 1 diabetes, pregnancy, renal impairment is one of the commonest in type 2 diabetes in adults, glycemic variability, duration of diabetes, alcohol consumption, overnight fast, elderly, cardiac failure, liver insufficiency, conventional treatment. So many of these are the problem with even the weight, exercise, or excessive medication can be the also reason for them to develop hypoglycemia too. The pathophysiological one is, it's a therapeutic hyperinsulinemia, either relative or absolute increase in the insulin level, either by exogenous or by giving secretagogue. There's an endogenous hyperinsulinemia, and that is the commonest cause. But other than that, it is not therapeutic hyperinsulinemia, actually renal failure, which is increasing the insulin level inside the body, and that also leads to hypoglycememia. And iatrogenic hypoglycemia is a concern because hypoglycemia caused by a treatment with sulfonylurea, glutamate, and insulin is the limiting factor in glycemic management of diabetes, and it causes recurrent morbidity in most people with type 1 diabetes and with advanced type 2 diabetes, and sometimes it can become fatal too. So the counter-regulatory response to hypoglycemia. First, brain detects there is an autonomic nervous system and there is a norepinephrine and acetylcholine, both increases. At pancreas, there is an increase in glucagon. So there will be actually post hypoglycemia, there is a possibility of hyperglycemia. The adrenal gland increases cortisol, epinephrine, both, and that also acts at muscle and fat to increase the glucose level. So hypoglycemia at brain have at autonomic nervous system gets excited, come in action, and also at hypothalamus and brain stem also. The putative mechanism of hypoglycemia unawareness. There are few patients who does not get the symptom of hypoglycemia because of recurrently they get hypoglycemia symptoms. Maybe at 70 or 69 or 59, multiple times their body is getting these type of hypoglycemia. And so that what happens over a period of time, they become hypoglycemia unaware. The maladaptive response in brain is characterized by increased GLUT1 activity in to preserve brain function and alter glucose sensing in VMH mediated by elevated level of GABA. The impact of glycemic variability, hypoglycemia and hypoglycemic recovery on the brain, the chronic inflammation and deplete antioxidant response, which increases mitochondrial dysfunction, oxidative damage, and chronic inflammation. So actually hyperglycemia and hypoglycemia both are responsible for increasing oxidative stress. So it's not like that only high sugar is responsible for oxidative stress or more for chronic inflammation, mitochondrial dysfunction. Rather, hypoglycemia also increases the risk of increasing oxidative stress too. The cardiovascular risk is very important because those who are having elderly with cardiovascular risk, we don't want them to go in hypoglycemia because hypoglycemia may increase the CV risk and mortality because hypoglycemia will have sympathoadrenal activity. Increased activation of this will increase QTC interval and hypokalemia. There will be more inflammation, more abnormalities, coagulation, and more endothelial dysfunction. And that may lead to cardiac arrhythmia, myocardial ischemia, cardiac autonomic neuropathy is already there existing and may lead to sudden cardiac death also. Accord and Advance. These two very important trial, US and Canada. Accord has been trial where they try to achieve a tight glycemic control, but these are the patients with 10 to 15 years of diabetes, and they just wanted them to have a very tight glycemic control, while Advance from all over the world where they want a tight glycemic control, but more with the glycoside. Here in Accord with any drugs, and almost similar type of patients number with baseline HbA1c were between 7.5 to 8.1, and they wanted them to have a very tight glycemic control. In Accord, what happened? It is terminated because of increased risk of all-cause mortality and severe mortality. So you can see that in patients with Accord who were trying to get tight glycemic control, there was increase in mortality, and they have stopped the this completely Accord trial too. So this Accord trial has been completely stopped or terminated, but Advanced trial had not shown any increased risk of all-cause or CV death. That shows that molecule used in that may be more cardiac safe, and the risk of hypoglycemia was also relatively less. The Accord was glimepiride with glycoside, and as I told you, there was no increase in body weight, and the severe hypoglycemia risk was also low. So how we should prevent the hypoglycemia? First and foremost is in education. Because when patient is given on sulfonylurea, or patient is given with glinides or insulin, patient therapy should be in such a way that it should be stopped. The newer approach to reduce hypoglycemia, it is improving pharmacological treatment, technological advancement, innovation in insulin therapy. The structured education reduces the risk of severe hypoglycemia and improve hypoglycemia awareness in type 2 diabetes. It is UK Daphne audit, which shows that all the patients with pre-education and post-education, hypoglycemia awareness and impaired awareness of hypoglycemia, both they try to find out. Daphne is a 5-day course for adults with type 1 diabetes that focus on adjustment of insulin according to carbohydrate intake and a reflective use of home blood glucose monitoring. So this is one of the most important part of education to the patient, that unless you educate the patient, you will not, if they are treated for diabetes with insulin and this, we should educate. This is a type 1 program where they have done a Daphne program also. There are technology, newer therapies, newer technology, and newer treatment modalities. There is a ability of insulin analog. So in compared to the regular insulin, if you use the insulin analog, probably the risk of hypoglycemia can be significantly reduced. Also, the real-time continuous glucose monitoring, this is one of the biggest advantage of putting the patient on CGM, and that can really decrease the risk of hypoglycemia very, very significantly, but more helpful for type 1, but for type 2 also. It can be, and we can achieve a time in range, a target range between 70 to 180. Then there is a insulin pumps had come over a period period of time, now we have 780G and we are getting the patients absolutely well controlled without getting any hypoglycemia because we have better insulin delivery, better warning, better prediction, and automated insulin delivery. To summarize my talk, hypoglycemia is a common occurrence in patients with diabetes. It is insulin in Chicago confer the highest risk of hypoglycemia among current pharmacological treatment options. Effective patient self-management is essential to reduce the risk of consequences. Empowering patient with education, tools, awareness, and individualized plan of treatment. Goal is to decrease the frequency and severity of hypoglycemia episode, as well as improving quality of life, health outcomes. Hypoglycemia and diabetes associated with increased morbidity constitutes a better to glycemic control, and the use of newer anti-diabetic medication with little or no risk of hypoglycemia and adopting feasible technology will reduce the risk of future of hypoglycemia. With this, there are clinical trial which had happened with cardiovascular outcome trial to show that even with the patient who are at the high risk of developing hypoglycemia, using the molecule which does not cause further hypoglycemia actually improves their cardiovascular mortality too. With this, I end my talk. I'll be very happy if we can have some discussion also.
Thank you so much, sir. Thank you for such wonderful inputs upon the topic that you have shared today with us. We have received few questions from the participants, and with all your due permission, I would like to put it across to you. Sir, the questions, can we put it across?
Yes, please.
The first question is, when should exogenous insulin can be considered as the etiology of hypoglycemia?
So whenever a patient is on insulin and he is getting hypoglycemia, we have to consider that it is the insulin which is causing the hypoglycemia, unless proved otherwise. So I mean the exogenous insulin, when patient is already on insulin therapy, we have to understand that this could be the cause for hypoglycemia.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And the question is, what organ system symptoms should be reviewed in the evaluation of hypoglycemia?
So whenever, first of all, I always go for the renal function test because the kidney is always a challenging. If it is a renal dysfunction, that could be the cause for it. But also the general overall examination. Then there are drug-drug interaction. Then where the person is taking the insulin injection, where the medicines, lipodystrophy, lipohypertrophy, multiple things are to be examined, and that decides that patient could be because of hypoglycemia, either because of renal failure, insulin dose, medicines properly not taken, what is the self-monitoring frequency, how frequently person is measuring, all those things, and history of hypoglycemia also. That's also important for that.
Thank you so much, sir, for answering this question. We'll move to the next question. The question is, what is the incidence of insulin-producing tumors causing hypoglycemia?
Please repeat the question. Sorry.
What is the incidence of insulin-producing tumors causing hypoglycemia?
So you are talking of insulinoma? It is the insulin-producing tumor you are talking, or you are talking of what is the frequency of hypoglycemia in person who is taking insulin?
The question is framed as this: what is the incidence of insulin-producing tumors causing hypoglycemia? So I would request
that
the
is
viewer.
very, very less. The insulinoma is not a very common tumor. Oh my gosh. It is not very uncommon, but not very common, because insulin-producing tumor or insulinoma is a rare disease in compared to the number of persons with diabetes, and they are getting hypoglycemia very, very high. So we have to rethink about the insulinoma only in condition when person is absolutely asymptomatic before some time, and then he started developing hypoglycemia. He is not on any oral hypoglycemic agent, then high index of suspicion, and then diagnosis, these patients will definitely confirm the diagnosis.
Thank you so much, sir, for answering the questions. That was the last question for today's session. And at the outset, I would like to thank all the viewers for their patient hearing and for their attendance here. With all this, I would also like to thank you, sir, for taking out your valuable time and for being here at our platform.
Thank you.